and I'd like to continue the presentation discussing ocular surface comfort and how we might improve the tear film for better patient outcomes with or without contact lenses. These are my financial disclosures. We know the tear film contains many important constituents and has a carefully ordered structure, allowing it to perform specific functions that are critical to good ocular surface health and comfort. From the epithelial-bound mucins, the glycocalyx at the base, which makes the surface hydrophilic, to the mucoaqueous phase that forms the bulk of the film, and then the thin but critically important lipid layer arising from the meibomian glands and sitting on top. Contact lenses have a major impact on the functioning of the tear film because of their size and the fact that they can move around within the tears. If we look at their relative thicknesses, we can understand why. The schematic at the bottom left shows the pre-ocular tear film, and on the right, we see what happens when we insert a contact lens, which, with today's soft contact lenses, could be up to 30 times thicker than that tear film. It splits the mucoaqueous phase into two, resulting in a thin pre-lens tear film with a stretched lipid layer that's expected to cover a greater surface area. This results in a very thin lipid layer, if a lipid layer is even able to be supported at all, and this disruption is reflected in reduced tear film stability. And this has a recognised impact on comfort in contact lens wearers. The poorer tear film stability, the higher evaporation rates, especially in adverse environments, and the tendency for incomplete blinking that we see with contact lens wear have all independently been associated with contact lens discomfort. This can then be compounded by other risk factors, as described in the recent CLEAR reports, such as pre-existing dry eye, lip cough or lid parallel conjunctival folds, as well as clinically significant Demodex infestation, which can all contribute to contact lens discomfort. So let me return to the lipid layer and its importance. This was recognised through clinical research using interferometry in 1995. Here we demonstrated in vivo that even a thin lipid layer, as long as it's continuous, is able to inhibit tear film evaporation. However, as soon as the lipid layer integrity is compromised, either visibly disrupted or clinically absent, the tear film evaporation rate increases about fourfold. And this research that formed part of my doctoral work was able to show that this tear film instability and increased evaporation rate was associated with increased tear osmolarity and ocular surface damage. And this is something we now recognise as the self-perpetuating vicious circle of dry eye disease, elegantly represented here by Baudouin, where we appreciate that there are many different triggers of this vicious circle shown around the outside here. But they all result in common features of dry eye disease: tear film instability, hyperosmolarity, ocular surface damage, and inflammation. And this is often driven by lipid deficiency, secondary to meibomian gland dysfunction, or MGD, represented here as the smaller inner vicious circle in its own right, that feeds into the broader, larger vicious circle through its adverse impact on tear film stability. And we know that evaporative dry eye, which is largely secondary to MGD, is a very common problem. If we look at the TFOS-DUSE-2 classification of dry eye with its two main subtypes of aqueous deficiency and evaporative dry eye, we recognise, in addition to the large degree of overlap, that evaporative dry eye is by far the more common, with around 86% of all patients with dry eye exhibiting an evaporative component. So this gives us great potential as clinicians to play a role in restoring tear film homeostasis to break that vicious circle. If we can break the inner circle by improving the tear film lipids, this might avoid the tear film instability that helps perpetuate the larger vicious circle, thereby breaking the entire vicious circle. And this is what was recommended by the TFOS-DUSE-2 management and therapy report led by Professor Lyndon Jones. Undertaking the recommended diagnostic testing will allow us to confirm the presence or absence of dry eye, but we require subclassification testing to be undertaken to best understand why an individual patient before us has dry eye, and to guide us in selecting our most appropriate treatment or combination of treatments based on the identified subtype or subtypes and their respective severity. So with lipid deficiency and the risk of lipid disruption being key in the pathophysiology of dry eye and a driver of patient discomfort, it would seem logical to attempt to create a more robust lipid layer, one that can better withstand the stresses that we expose the tear film to, including contact lens wear. Research shows us that if we supplement the preocular tear film with natural lipids expressed from the meibomian glands, we can improve the tear film stability. So it pays for us to concentrate on improving meibomian gland function. So I'm going to focus the remainder of my presentation on describing how we might go about doing this, with the longer-term aim of improving patient comfort, using a three-step approach. Firstly, preparing the lid margin, then encouraging meibum outflow, and finally optimising the tear film lipid layer. Preparing the lid margin involves removing lash crusting and reducing bacterial and Demodex load at the lid margin as appropriate. Patient engagement in this process is critical, as the care for this chronic condition needs to be administered at home on an ongoing basis. Dedicated lid cleansers are recommended for the sensitive ocular tissues rather than baby shampoo, which can damage the goblet cells. And be aware that a number of products contain anti-demodectic components if needed, such as tea tree oil. Patient education and follow-up are key in ensuring appropriate application methods and to identify any need for a refinement in treatment plan. In more severe cases, or simply to give the patient a head start, there are a number of in-office treatments that can be applied, such as microblepharoexfoliation, which offers a deeper clean of the lashes and surrounding area. Keratinized material on the lid margins blocking the gland orifices can be gently removed with an epithelial debriding tool or golf club spud. Again, look out for Demodex and treat accordingly, ensuring that the mites at all stages of their life cycle are targeted. Such lid hygiene education and application are increasingly being recognised as vital parts of MGD and dry eye management, and raise the question of whether there's a role for ocular hygienists in practice, trained individuals with delegated authority to advise patients and apply simple treatments. So with the lid margin prepared, the next stage is to encourage meibum outflow. This often requires heat to help melt the inspissated oils. Again, this is most commonly an at-home treatment for patients to manage over the longer term. Warm compresses work optimally when they apply at least 40 degrees heat for 10 minutes. So you'll likely need a microwavable compress to achieve this. Washcloths warmed in hot water don't retain sufficient heat. Latent heat devices can offer periocular heat without pressing on the eyes and work as effectively as warm compresses. Encouraging outflow of the oils after warming is important, and patients might achieve this with gentle digital manipulation of the lids or with a dedicated silicone expression device. An increasing number of practitioner-applied treatments exists for in-office application. These include treatments that heat the meibomian glands from the palpebral conjunctival side this time, rather than the outside. There's also intense pulsed light, and low-level light therapy has received some interest in recent years. And where treatment doesn't include inbuilt expression, it's typically followed by therapeutic gland expression performed in office. Finally, if the lipid layer is still not of an optimal quality to be able to remain continuous over the surface, or if there's simply not enough lipid, you might need to consider some additional treatments. Improvements in lipid layer quality have been observed with low-dose antibiotics that are employed for their anti-inflammatory benefits as much as for their antibacterial properties, as well as with higher levels of omega-3 essential fatty acids in the diet. For patients unable to achieve an adequate lipid layer from their natural lipids, there's an increasing range of supplements that contain lipids either in a spray form, as lipid-only drops, or as lipid aqueous combination drops, which seek to supplement both the aqueous and the lipid components of the tears. So in summary, by adopting a careful stepwise approach that takes advantage of the wide range of options available, practitioners and patients can work together on creating a more robust tear film to achieve improved patient comfort. Thank you very much for your attention.